Well, good morning all, and those were certainly two very interesting presentations. I'm going to change tack just slightly and talk more about the doctor as having risk as opposed to the risks that we might pose for our patients. But inevitably, if we are at risk as doctors, then our patients are going to be at risk because a risky doctor will automatically have patients who are at risk. So I want to talk a little bit about the counselling service that was set up as a joint program between MPS and the Medical Assurance Society, and look at the analysis that we did of that, and then look at some of the stressors that apply to doctors in their working environment, and rather grandiosely look at what the future holds. And this will be slightly tongue-in-cheek when I get to that point. Of course, our crystal balls that we all have are incredibly accurate. So if I get the button to work, yep. So the background: we in New Zealand, in theory, have an incredibly benign medico-legal environment. In the whole time that I've been working with MPS, not a single member has been sued in court as a result of their work as a medical practitioner. And so we just don't have that fear of large amounts of money being lost, whether it's our insurance company or ourselves, from our actions as doctors. Medical manslaughter is also exceedingly rare in New Zealand. The bar was raised in the mid-2000s, and there hasn't been a successful prosecution for medical manslaughter in New Zealand for at least 12 to 15 years. So as a result of all this, and with ACC, of course, and treatment injury, which has been alluded to, our indemnity costs are very low. So surely working in this kind of environment must be pretty relaxing for doctors in New Zealand, no stress, and how could we possibly think otherwise? So there are some other sides, of course, to that story. Now, one of the first ones is that the ease of lodging a complaint in New Zealand. It's just incredibly easy to do so. And with the HDC, of course, now, if a patient doesn't feel that they're able to lodge a complaint either by writing or emailing or even ringing the Commissioner's office directly, they can make use of the advocacy service, and there are advocates throughout New Zealand who will assist patients to lodge their complaints. So it's a very easy process to undertake. And then there's just the sheer number of organisations out there that have some power over us. And we've already heard today how it's those external powers that create most difficulties for us. And in fact, so much so that one of the earlier CEOs of MPS internationally regarded New Zealand as being the most hostile medico-legal environment that MPS operated in at the time. It seemed bizarre, but when you look at the number of different organisations that can get involved, and often simultaneously. So we can have a doctor involved in 3 or more sometimes of these processes at the same time, all with different potential outcomes, but then all which may be cumulative. And of course they're all interlinking, so the police might get involved, and then they might decide quite off their own bat they're going to inform the medical council directly rather than waiting until there's been a prosecution. The ACC, although it's a no-fault system, unfortunately it's not a no-risk system as far as treatment injury is concerned. So doctors, if our competence is questioned as a result of our actions with a patient, and ACC picks up on that, then they can refer either through to the Medical Council or to the Ministry of Health, both of which can have significant consequences. And then things, of course, get more complicated when you look at the potential outcomes from many of these things. And you look at some of the numbers associated with these, and, damages of 200,000 through the Human Rights Review Tribunal or the Health Practitioners Disciplinary Tribunal. Those are big numbers. With the HRRT, until recently it was a doctor who had the highest damages, and that was $40,000. More recently, the case of the departure cake from Hawke's Bay trumped that, and for those of you who know, that was now $160,000 has been awarded through the HRRT. Not a doctor involved in that one. So when you look at this slide, the 1,000 arrows slide, you suddenly think, well, actually, maybe it's not quite so benign after all. And it was certainly in that environment that Wayne Cunningham did some work in the early 2000s and published looking at the impact of complaints on doctors. And as a result of his surveys, he found that doctors regarded the medico-legal environment as being complex and threatening, and that as a result of receiving a complaint, a whole lot of different emotions came to play. Anger at the person for lodging the complaint often, particularly where it was felt to be not a justified complaint. Depression, and that's particularly if we really have done something wrong. I think as doctors we never go out there with the intention of causing harm, but inevitably harm does happen. And that leads on to shame and guilt. And then more insidiously, there's the reduction in trust in our patients. So if we've had a nasty complaint against us, the next person who comes into the room, are you going to be the next person who complains about me? And if you are, well, I've had enough, basically. So we end up with reduced goodwill to our patients, and it's not a great environment if we don't have goodwill to our patients in that setting. And then just this reduced sort of sense of ability to work, whatever that really means. So as a result of that, we decided to set up a counselling service. We decided to make it available to any doctor in New Zealand. It was going to be nice and easy to access, just an 0800 number to ring, and most importantly, we thought it was going to be anonymous, so none of the organisations that funded it would get any identifying details about the people who rang. Originally it was designed to be provided the service by either a psychiatrist or a clinical psychologist, and it was of the doctor's own choosing. Subsequently we've now limited that to clinical psychologists only. And originally, because we had no idea how the service was going to be used, doctors could have an unlimited number of sessions, and as a result of looking at it now, the usual maximum is 6, but that can be extended if required. Soon after we started it, when we thought we had enough doctors who'd used the service to be able to get some kind of idea of the value of it, we decided to do a review and to aim to try and publish it. So we got ethics approval for the study. First thing we did was we sent out a questionnaire to all of the providers, all of the psychologists and psychiatrists who had helped our members, or the doctors who'd used the service. But then the tricky bit was we wanted to get the doctors themselves, of course, to give us an idea of how they valued the service, but we didn't know who they were. So our way of getting around this was that we then sent the doctor's questionnaire to the provider and asked them to hand it on to the person that they'd been treating. And we didn't have a great deal of optimism that that would work, but it was the only way we could think of doing it. At the same time, we also sent a questionnaire to doctors who'd received an HDC complaint, and we just wanted to see if we get sort of some confirmation of Wayne's earlier work in terms of the impacts. So at that stage, there'd been 55 doctors who'd accessed their own nominated psychotherapist, be it psychiatrist or psychologist. There'd been 41 different therapists who'd been involved in providing the service, and we got a pretty good response rate from the therapists, and actually at just under 50%, we thought that was a pretty good response rate from the doctors as well. So you can see not huge numbers involved, but we hoped it was enough to give us some idea of the trends and whether or not the service was worthwhile continuing with. So this is what we got. About 60% were GPs, and that's about right for what we would expect given the demographics of doctors around the place. Likewise with their location, urban or rural, and around 50% had graduated from overseas, and that's about what the demographics of doctors in New Zealand are. So that was representative. We had the usual 2/3, 1/3 rule that applied. So 2/3 of the doctors who used the service used only 1/3 of the actual number of sessions that had been provided in total, and of course the converse was true. And we had 2 doctors who went up to a maximum of 22 sessions. It was actually a really big time investment, isn't it? 22 sessions of an hour with a psychologist or psychiatrist. So they clearly thought there was value in the session. The doctors, we were pleased to see, thought that actually this was a really valuable service for them, and you can see that around just over 80% thought that it either had significant benefit or was extremely beneficial for them. We also wanted to ask the providers their opinion as well, because it was so difficult asking doctors through this sort of convoluted system, that we thought if we're going to review the system in future, if there was a reasonable correlation between what providers thought and what doctors thought, then actually we could make it easy for ourselves in future by just asking the providers. And they were actually slightly less enthusiastic about the benefits of their own interventions, but still most of them thought it was a pretty positive sort of intervention for those people involved. One of the questions that Medical Assurance was interested in, because of course they provide a lot of insurance in terms of not being able to work, and so they wanted to know whether the use of the service would actually help people stay at work. And interestingly, most of our doctors felt that yes, that it really did have a significant impact on them either being able to continue on at work or resume work if they'd been actually off. We also wanted to ask, in terms of the long-term provision of the service, what were the most important aspects for any individual doctor. Confidentiality clearly was up high, though I was surprised to see that it wasn't sort of 100% extremely important. A choice of clinician was regarded as being very important as well, and interestingly, the lack of cost actually was up there as well. You know, we're not poor in terms of a profession, so it surprised me somewhat that the actual not having to pay was a really important factor for many of the people who use the service. So why did people present? Well, about 30% attended because of stress related to a complaint, so we had anticipated it might be higher than that, but that was still a reasonably good number in terms of the original intention of providing the service. And then the rest presented for the other things that you might reasonably anticipate: work, home, and then personal problems. Kind of work stresses, you know, there's work overload due to staff shortages. Well, nothing's changed there. Unrelenting standards leading to burnout and depression, and of course these are externally imposed standards, not ones that we've come up with ourselves in terms of improving situations. Conflict and lack of effective communication, and then workplace bullying, which unfortunately is still very prevalent out there in the community. We managed to get quite a good sort of trend in terms of why doctors presented. So the ones who only presented for a short number of sessions, they were mostly the work stress or marital and social problems and needed a relatively short time to sort those out. But the ones who needed more than 10 sessions, and it was a significant percentage, though, as I say, of small numbers, all of these had significant psychopathology. So there's a lot of hidden psychopathology out there amongst us that wasn't being recognised. And as I mentioned, we had 3 doctors, 2 of whom had 22 sessions. So the underlying problems that were picked up: bipolar disease that had never been assessed. So this was a person who'd gone through medical school with his bipolar disease, never been diagnosed. Long-standing depression and anxiety, never before treated. Past sexual abuse, and not surprisingly, given that we're particularly at risk of this, alcohol and addiction issues. So, as a result of the study, we felt that yes, the doctors who were accessing the service did find it to be beneficial. There was some comment that actually it hadn't been particularly well publicised, and so we took that on board. Though we did worry what the implications might be financially for us if much greater numbers decided to access the service. And then we had the underlying sort of conundrum about these serious health issues that had emerged and what we should do about them, of course, because as you know, if we as a health professional become aware that any of our colleagues has a health issue which might limit their ability to practice safely, then we are obliged to report it to the Health Committee of the Medical Council. That was one of the reasons why we also wanted to make it anonymous, because that would at least would make it easier for us at MPS to avoid being stuck in that conundrum. But some of the therapists did in fact report the health problems to the Health Committee, or they managed to convince the doctors who had those health problems that they should self-report, which is of course an obligation on us as well to self-report. So what's happening with the service at the moment? Look, it's staying steady. We get about 90 to 120 inquiries per year, and about 3/4 of those doctors end up using the service, and the numbers are staying pretty stable over time. So our fears of it suddenly expanding exponentially haven't been realised. The number is set at 6 maximum, but in fact most members use an average of sort of 4.5 to 5 sessions, so that number of 6 is about right. But we allow extra sessions if people feel it's particularly warranted, and over that period one has had 13 sessions. Who's using the service? Well, it's about just over 50% are GPs, and that ties in quite nicely with our earlier survey where it was 60%, so the numbers seem to be representative there. Clinical psychologists, originally it was just for doctors, but we then realised, well, actually we've got members who are not doctors, and so we needed to open it up wider. They are the biggest user on a per capita basis of our service. Not too surprising really, they're very used to that kind of service and would naturally feel much more comfortable with it. But a reasonably high number of registrars and house officers using the service as well, which I think is really good. Auckland is dominated, of course, but that's not surprising here. We've got a lot of different psychologists who provide the service, and most of them only will treat one member in that 4-year period. But we've got a small group of psychologists who seem to have a specialty in treating doctors, and some of them have seen 10 or more individual doctors. So is there still a problem? What's happening out there? So yes, we think there is. In the UK, it was reported recently that 30 doctors have committed suicide in the last 5 years while they've been under GMC investigation. How much of a factor that was is impossible to tell, but it's certainly going to be a factor. A recent Pulse survey in the UK suggested that 50% of GPs are at high risk of burnout. MPS in the UK has also done a survey as well about psychological health. A third of the respondents had depression. 75% said their workload was having an impact on their mental health, and a quarter had said that a patient complaint or claim had affected them and their health. And interestingly, 40% of those who had issues that responded to the survey didn't discuss them with anyone, and that always seems to me to be incredibly sad. What we found in another questionnaire that we did was that in fact colleagues are the best form of support for doctors who have received a complaint or in trouble with stress of any sort, and so using those resources that we have around us is really important. When we did that survey, as I mentioned, about the impacts, we wanted to see for people who'd had a complaint to the HDC how that affected them. And this was particularly relevant because the HDC always has the view that complaints are a positive thing, that we learn from them, that systems are improved, and that therefore they should be, if anything, embraced by the medical community and the health community rather than the other way around. The reality from our side of that equation is that that doesn't happen. And although maybe a third said actually it hadn't had a big impact on them, you can see that a good 2/3 probably had either a negative or a very negative impact when we asked them about a variety of things like impact on emotional health, impact on their personal lives, their enjoyment of work, which clearly is exceedingly important. Why would we keep going to work if we didn't actually enjoy it? And this very loose term, our ability to practice, how good do we feel about working? So, with that then, I had a wee look at the activities of both the Medical Council and the HDC to try and get some idea of how much of an increased impact is this going to have on us over time. And it was interestingly, I went back to 1988 because that was the year I started in general practice, and it's rather sad but to have to admit it, but I actually found reading the annual reports of the Medical Council quite interesting over that period. And at that stage, 1 or 2 doctors a year were removed from the register. Actually, it's not a great deal more now. So the actual, the final solution, if you like, of being removed from the register doesn't happen very frequently. But there was a specific comment in 1988 that the number of cases had jumped from 4 to 19 in that year. The commentary around it was that a contributing factor was the increased willingness of patients to lay complaints, and they said prophetically that undoubtedly this was a trend, and it was one that will continue, with my exclamation mark added to that. Now, you remember that there was no Health and Disability Commissioner at that stage, so those 19 cases were the official complaints that came into any official organisation at that time. What's happening with the Medical Council? Well, they've been pottering along fairly steadily with their performance assessments, so these are doctors who are regarded as being at risk in terms of competence and needing to be checked. But just recently there seems to have been a bit of a nudge up. A little difficult to tell because they changed their method of reporting in 2013, so these figures may not be entirely accurate, but they do suggest there's a bit of a trend, whereas the health notifications have stayed sort of static over that time. So, not being a statistician, I've taken a great deal of liberty with these numbers. And I've taken kind of two scenarios, depending on which way you look at that little blip up in the curve that was happening at the end here when we were seeing sort of in the 40s and then 50s and nearly 70. And in another 10 years' time, the Medical Council will either be seeing a relatively modest sort of 250 or so performance assessment cases, or it'll be up to the 1,200, depending on whether that trend continues. So 1,200 per year. There's about 15,000 doctors, I think, working in New Zealand. So that's 1 in 10 of us are going to have a performance assessment every year. Our subs for our APCs are certainly going to go up if that happens. What about the HDC? Well, this is grimmer reading, I'm afraid, because these are the stats, admittedly only a very short period of time, that look at what's happening with the Health and Disability Commissioner. So, the number of new complaints, as predicted by the Medical Council back in 1988, are steadily increasing, but not at a huge rate. It's faster than the population increase, but it's kind of a level that we could probably live with and accept. The Commissioner's making a good job of trying to close complaints. Having said that, though, I don't know if those of you heard the interview with Kim Hill and the Commissioner not too long ago, where she grilled him over the length of time that some of these investigations were taking, more than 2 years for some of the more complicated one, which is a really long time for patients to be sitting not knowing the outcome of their complaint, and especially from our side for the doctors to be uncertain. But these are the numbers that are concerning me. So the number of investigations has jumped by 161% in that period, and then the numbers of referrals to the Director of Proceedings, which is the route on to the Health Practitioners Disciplinary Tribunal, they've increased by 187%. So, admittedly, very short time period, but it does raise some questions. You know, those are big jumps. Have we suddenly become much less competent in that time? Doesn't seem particularly likely. So clearly something's changed within the office of the HDC that has led them to believe that a lot more needs to be done. And this could, if those trends continue, certainly have some significant impacts on us. So I've done some, again, very scientific, non-scientific calculations. By 2019, only 4 years away, there will be as many investigations as there are complaints. So every single complaint that the Commissioner gets, according to those numbers, he'll be investigating. By the following year, there will actually be more breach findings than there are complaints coming in at all. By the following 2 years later, there will in fact be more referrals to the Director of Proceedings than there are complaints. But the major projection that I've made from this is that I'm going to need to retire by 2018, which is only 3 years away, which is a bit of a worry. So, the conclusions then. You know, we are in an inherently stressful profession. You know, we carry huge responsibility every day, and that has a toll. It's inevitable that the scrutiny by external agencies will increase, and we know that scrutiny increases the stress that we're under. And that scrutiny is going to increase despite any evidence that our standards are dropping. In fact, I would argue that standards are improving steadily of provision of medicine, and yet the scrutiny is getting higher. In the UK, the GMC wants to build in resilience training to all its young doctors so that they can cope better with the stress of complaints. Maybe this is something we need. But until that happens, you know, there is help out there. As I mentioned, colleagues are our most important asset in terms of assisting us through difficult times. But there are services such as the counselling service. So, thank you very much.